Okay, sir, we are live. We can begin.
Okay. Hi and good evening, friends. I'm Dr. Ameet Patki, and thank you for joining in on this webinar. We are all going through a very trying times all over the world, but this has also given us some time to pause and reflect back. And what better opportunity than today or these days to refresh and recap and discuss and have an interactive session on another problem which is griping the obstetrics and gynecologist, which is the polycystic ovarian syndrome. Okay. Okay. As Voltaire had said, the art of medicine is to amuse the patient while nature cures the disease. This is true for even COVID, where medicines don't act as much as nature, but it is also true for polycystic ovary, where we know that although we can prescribe a large number of medicines, it is change of lifestyle which naturally cures the disease. There is also another very old Zen saying which says, we teach best of things, we want to learn more. Polycystic ovarian syndrome is one of the biggest nightmares of any fertility specialist. Is a bigger nightmare even for gynecologists when they're not trying for fertility. And it is the biggest nightmare for the patients and perhaps her family because of her irregular periods, her weight gain, her androgenic signs. So, ladies and gentlemen, have we reached the crossroads in management of PCOS? There is a large plethora of medications that are now available to manage PCOS in various age groups. But what is polycystic ovary syndrome? Way back in 1990, the NIH and the NICHD conference on PCOS, where a large number of the PCO experts had gathered, could not endorse even one criteria as definite or probable by those experts. So it is not only a confusion in our minds, mere mortals, but it was a confusion even then in experts. At the end of the 2-day seminar, they came up with possible criteria, which is insulin resistance, increase in LH-FSH ratios, and polycystic ovaries on sonography. Then, a few years later, in 2003, we had the Rotterdam Eshrei ASRM consensus, which said that any two of the three, which is oligo or anovulation, clinical and or biochemical hyperandrogenism, and polycystic ovaries on sonography as diagnostic features for PCOS. But it was a consensus, and then Michael Crichton, who's a renowned medical writer, said there is no such thing as consensus in science. If it's consensus, it isn't science. If it's science, it isn't consensus, period. So consensus, he said, is invoked only in situations where the science is not solid enough. We have a corollary in our COVID where we know social distancing is science, but perhaps taking prophylactic HCQ may be a consensus, may not have solid science. In 2018, we had the International Evidence-Based Guidelines for Assessment and Management of Polycystic Ovarian Syndrome, Herculean joint effort by ASRM, ESHRE, and the Monash universities. But why is PCOS so relevant to our current clinical practice? It is because it is the most common endocrine dysfunction amongst women who are in the reproductive age between 14 and 45, may occur in almost 18% of women in the reproductive age, and is associated with abnormal GTTs, increased risk for type 2 diabetes and hypertension. Fibrinolytic and lipid derailments are also observed in PCOS. So it is not only the women in the reproductive age that need to be counseled, to be treated, or even diagnosed. PCOS starts right from adolescence age. We need to look after our young girls so that they do not have the problem in the reproductive age. And we need to monitor women even after they've finished their families so that they do not develop the metabolic X syndrome that we fear would occur in women in the perimenopausal and the menopausal age. So if you go by the phenotypic classification, the type 1, which is the classic phenotype of PCOS, and which is found in over 55% of the women, is hyperandrogenism, chronic anovulation, and polycystic ovaries on the scan. The type 3, which occurs in almost 30% of the women, is hyperandrogenism and polycystic ovaries, but women having perfectly regular ovulatory cycles. So between the type 1 and the type 3, it takes care of almost 85% of the women. The type 2, which is found in approximately 9% of the women, is hyperandrogenism and chronic anovulation, but normal ovaries on sonography. And another approximately 8%, which is type 4, is chronic anovulation and polycystic ovaries, but no clinical or biochemical hyperandrogenism. So anovulation is a problem in approximately over 70% of the women. Now, what is the differential diagnosis for polycystic ovaries? One that we are seeing very regularly now is decreased ovarian function or premature ovarian failure, autoimmune problems causing POF, iatrogenic problems like previous history of radio or chemotherapy, destroying the ovarian function to a large extent. The other possible endocrinological conditions that can mimic anovulation is hypothyroidism, typically subclinical hypothyroidism, where the TSH would be in the higher range of the normal range, adrenal disorders, congenital adrenal hyperplasia, Cushing's disease, and very rarely adrenal tumors. But in this group, clinical subhypothyroidism is something which is very important and needs to be tested and treated. Hyperprolactinemia is another endocrinological factor that needs to be looked into in chronic anovulation. So when you have young girls who come to you with PCOS, besides telling them about lifestyle changes, diet and exercise, if they need to be given medications, the use of the combined oral contraceptive pills is excellent, works very well, and can be taken for large duration of time. It can regularize menses. Because of its anti-androgenic effect, it can work on the hyperandrogenemia, and it will reduce the LH levels, which is the chronic problem for an ovulation or even for prolonged periods of amenorrhea. We do not like to use the anti-androgenic oral contraceptive pills at the first choice because in most women, the COCs would work well and are better suited and can be taken for prolonged duration, even years, so that they get regular periods and they are fine. Now we have a second group of women who would want to have regular menses without using the contraceptive pills because they would like to have their fertility maintained. In such women, the use of progestogens or progestins for regular menses helps. We give them cyclical progestogens for 10 days so that it will ensure regular menses and also prevent endometrial hyperplasia, which is found in chronic anovulation and in prolonged periods of amenorrhea. So such women would take the progestogens maybe after every 35 to 40 days so that they have regular shedding of the endometrium. So endometrial hyperplasia is also not happening. And if they conceive, we are not giving them any contraceptive pills. So they are open to get pregnant and they can maintain their fertility at the same time. But almost 75% of women in the reproductive age with PCOS have irregular menses and or infertility. Majority of them manifest as primary subfertility, and anovulation is the main cause of infertility in women with PCOS. The drug that has been used for decades and was the gold standard till the last 2018 review of PCOS was clomiphene citrate. We all know the mode of action. It enhances the natural HPO axis. It interrupts the estradiol negative feedback and release of HPO axis from inhibitory effect of the circulating estrogens. So because it blocks the negative feedback, there is more stimulation of the FSH, leading to a multifollicular growth, follicle maturation, which then enhances ovulation. So who will respond to clomiphene citrate? Remember, only women with normal responses from the HPO axis to low estrogen levels. So if the HPO axis is blocked for some reason because of some medications, clomiphene citrate will not work on such women. Typically, women who have been given GnRH agonist depots for prolonged periods when their HPO axis is blocked will not respond to clomiphene citrate. So what are the indications for clomiphene citrate? Ovulation induction in an anovulation or an oligo-ovulatory infertility, ovulation augmentation in unexplained ovulatory infertility, and controlled ovarian stimulation, COS, in all ART cycles. What are the disadvantages or the drawbacks? Although ovulation rates are high, pregnancy rates are relatively low, and this is perhaps because of its peripheral anti-estrogenic effect. Clomiphene citrate has a long half-life. Estrogen receptor depletion or downregulation happens with clomiphene. And we have also seen it has a higher than expected rates of miscarriage. So ideally, clomiphene should not be given back-to-back cycles. We need to give a drug-free cycle between treatment cycles. We have to ensure that the endometrium is optimum on clomiphene. So follicle monitoring is extremely important even when the patient is on clomiphene citrate alone. And if you find that your patients are having persistent early miscarriages, or persistent luteinized unruptured follicles on clomiphene citrate, I think we should be stopping clomiphene citrate and putting them perhaps directly on gonadotrophins. So what is the other way to treat women with PCOS? It's the letrose. It's a triazole derivative, third generation non-steroidal aromatase inhibitor. It is a competitive inhibitor, highly selective, leads often to monofollicular development, and a very potent ovulation induction agent. And now the drug of choice, the first drug of choice in patients with anovulation because of polycystic ovarian syndrome. So letrozole would be the drug of choice, particularly in PCOS patients. So how does this letrozole work? The FSH increments stimulate production of aromatase itself. High levels of androstenedione bring about a reversal in action of letrozole. And the beauty of letrozole, it has a very short half-life, so it enables the peripheral effects of estrogen and doesn't cause immense damage or inhibition of endometrial growth. It has to be given in a dose of 2.5 for 5 days. Quite often we have given it for 5 milligrams for 5 days. There are certain studies which have shown a single dose of 20 milligrams on day 3 of the menstrual cycle. So when you compare letrozole with clomiphene, you find that not only the endometrial development is enhanced as compared to clomiphene in letrozole cycles, it has a short half-life, so can be given in back-to-back cycles. The uterine blood flows are increased in clomiphene as compared, increased in letrozole as compared to clomiphene. And because of all these three factors, it gives you a monofollicular development as compared to a multifollicular development, which often happens with clomiphene. Letrozole gives you a higher pregnancy rate than clomiphene, and hence is the drug of choice in polycystic patients. But all, whether it's the letrozole or clomiphene, they both need to be monitored. So patients have to come for follicular monitoring, and that can be sometimes a disadvantage as far as logistics for patient is concerned. So we are always looking for newer agents or alternatives to both of them, clomiphene or letrozole, preferably an alternative which can be given oral because the patient compliance is much better, without high risk of multiple pregnancies or even multiple cyst formations, and requiring minimal or no monitoring at all. So do we have such a drug? Before we go on to the drugs, let's look at the key pathogenesis in polycystic ovaries, and it is the insulin resistance. So the insulin resistance, which causes compensatory hyperinsulinemia, is the key in the pathogenesis for polycystic ovaries. It is present in approximately 80% of obese women with PCOS and in 30 to 40% of lean women. So remember, lean women can also exhibit hyperinsulinemia and insulin resistance. May not be as much as the obese, but almost half of them will have hyperinsulinemia, and the drugs that we give for obese hyperinsulinemic women can be also given to such lean, thin women. So insulin resistance will work on multi-organs. It works on the pancreas, making it work over time because of hyperinsulinemia. And that's one of the reasons if these women are not supervised, are not medicated, are not told about lifestyle, weight loss and exercise, they may run into pancreas getting tired and getting diabetes. It also, the hyperglycemia works on the liver, where there is increased synthesis of fatty acids and increased adipose tissue, leading to obesity. The insulin resistance will work on the ovaries, causing hyperandrogenemia. So the root cause is insulin resistance, leading to hyperinsulinemia, leading to hyperandrogenemia, leading to polycystic ovaries, which exhibits as menstrual irregularities, acne, hirsutism, obesity, and infertility. So there is a role for insulin sensitizers. Now, what do these insulin sensitizers do? They increase the sensitivity of insulin towards the receptor, thereby decreasing hyperinsulinemia. Very simply, it will make the cells sensitive to the insulin, thereby decreasing the hyperinsulinemia that is associated with insulin resistance. There are a large number of drugs in the market, one of them being myoinositol and D-chiro-inositol. So myoinositol links to cellular glucose uptake. It is present in high concentrations in the ovary, and it will improve ovarian functions. On the other hand, the D-chiro-inositol is present in high concentrations in glycogen storage tissues, such as the liver, muscles. It has no effect on the ovarian level. It mainly links to glycogen synthesis, rapidly reduces peripheral hyperinsulinemia. So both myoinositol and D-chiro-inositol need to maintain a perfect balance to maintain a normal glucose levels. So the myoinositol is high concentration in the ovary, acts on the ovary, increases cellular glucose uptake, thereby decreasing the hyperglycemia. And in right proportions and concentration in the ovary will increase the oocyte quality and number of oocytes that mature on stimulation. The D-chiro-inositol, on the other hand, is high concentration in glycogen storage tissues such as the liver, muscle, and the fat. Although it acts at peripheral tissues, but it has no role in the ovary, it increases glycogen synthesis, thereby decreasing hyperglycemia, reduces compensatory insulin production and hyperinsulinemia. And D-chiro-inositol, by reducing hyperinsulinemia, reduces conversion of myoinositol to D-chiro-inositol at the ovarian level. So this is called as an insulin paradox. So when there is insulin resistance, there is decrease in the myoinositol. Because there is decreased myoinositol to D-chiro conversion, and there is also decrease in the D-chiro-inositol. Because of both, there is hyperinsulinemia. So a combination of myoinositol and D-chiro-inositol will improve this balance and will reduce the hyperinsulinemia that is present. Myoinositol also has improving qualities on the oocyte because it increases the FSH signaling, so you have better oocyte quality and maturation. High levels of D-chiroinositol can have negative effects on fertility because it impairs estradiol synthesis because of sharp inhibition of aromatase, thereby increasing androgen levels. And because of hyperandrogenemia, it will decrease oocyte quality. So what is the ratio? It is 40:1 ratio of myoinositol with D-chiroinositol, effective glucose utilization and uptake. There are various papers which have said in clinical practice that myoinositol is superior, and a combination of myo and D-chiro in the ratio of 40:1 seems to be a promising approach. So the combined administration of myo and D-chiro should be considered in overweight PCOS women to reduce the metabolic and clinical alterations of PCOS, thereby reducing the risk of metabolic syndrome. But as I said, when you are at the crossroad, when you have an array of drugs available, we can also look at metformin, which, like clomiphene citrate, has been in usage for many years, for many decades. Large number of studies which have shown that metformin is also as effective as an insulin sensitizers in PCOS women. So can we combine inositols with metformin? What should be the ideal dose? These are questions that we can take up later. However, there are suggested uses where we know that myoinositol works very well in the young adolescent PCOS, in lean PCOS. The combination of myo with D-chiro in 40:1 works very well in the obese PCOS, in the infertile PCOS needing ART, and the combination of inositols with metformin works very well in women with severe insulin resistance, not responding to either of them. So a combination of metformin and myoinositol works very well. And the other group that it works very well is the perimenopausal PCOS women, women at the perimenopausal age showing early diabetes mellitus. We all know how metformin works. It suppresses appetite, and when combined with diet and exercise, it enhances weight loss. It is also available in an extended release, which is better tolerated. You start with very low doses and then increase the dose to a maximum of 1.5 to 2 grams daily. In women who have taken metformin for a minimum of 3 months, there have been papers which have suggested menstrual cyclicity in almost 30% to 40% of them, reduction in BMI to an average of 2.8, and spontaneous ovulation in 30 to 40%. So metformin, which is combined with a hypocaloric diet and exercise, will give us metabolic improvements by reducing the testosterone levels, reducing the insulin levels, and significant benefit is when there is a 10% weight loss. So when there is a 10% or a 10 kg weight loss, we find that there are metabolic changes and spontaneous ovulation and pregnancy, cycle menstrual cyclicity or regularization of the cycles, and reduction of BMI is possible. We used to all continue metformin in early pregnancy because there were papers of 2002 which suggested that perhaps it decreases miscarriage rates. In the latter meta-analysis and Cochrane data, this was not shown to be true, but we still continue metformin in the first trimester because it has been shown to give us a better live birth rates in women who have taken metformin in the first 3 months of pregnancy. So patients of yours who conceive on metformin, you should continue the metformin till 12 weeks of gestation because it will give you a better live birth rate. So as I said, when you combine metformin with a hypocaloric diet, it has got an additive efficacy or an additive benefit because there is greater reduction of body weight, particularly the abdominal fat, particularly visceral fat depots, decrease of serum insulin, testosterone, when metformin has been used in a dose of 850 twice a day as compared to placebos. So metformin alone showed a statistically significant increase in ovulation with an odds ratio of 2.9, which tells us in layman language that it gives you a 3 times better ovulation induction rate as compared to placebos, but did not show a statistically significant increase in early pregnancy or live births. But metformin, when combined with clomiphene, showed a statistically significant increase not only in ovulation with an odds ratio of 4.3, that means the combination gave you 4.3 times better success in ovulation, and in pregnancy rate with an odds ratio of 2.6 as compared with clomiphene citrate alone. So women who do not respond to clomiphene citrate may do better when you combine it with metformin. So which is the group? It is the obese and the clomiphene resistant group which did better when metformin was added to the regimen. However, as I said before, it may not improve your miscarriage rates, but definitely giving metformin in the first trimester has shown to give us a better live birth rates. So when you compare CC and metformin in clomiphene resistant patients, when you compare it to gonadotrophins, obviously the gonadotrophins gave you a much better ovulation and pregnancy rates, which are statistically also significant. But you must understand that gonadotrophin needs much stricter monitoring, needs transvaginal sonographies done on these women to prevent hyperstimulation, needs expertise, and is much more expensive. The combination of metformin and clomiphene when compared with laparoscopic ovarian drilling showed similar results. So particularly in the thin, lean PCOS who have got anovulation or chronic anovulation will do better when you do an ovarian drilling for them rather than telling them lifestyle changes, because lifestyle changes are not going to be of much benefit to these women. So although there is evidence of superiority of gonadotrophins as compared to metformin and clomiphene combination, we know that gonadotrophin is the next step from clomiphene and metformin, but you may continue it in areas where there is limited access to gonadotrophins, maybe because of the area where the patient stays, or even because of availability of gonadotrophins, or the buying potential or the spending potential of the patient. Now, metformin, previously we used to document hyperinsulinemia and then put patients on metformin. But newer research suggests that there is improvement in the reproductive function even in patients who do not exhibit biochemical hyperinsulinemia or glucose intolerance. We know metformin can be safely continued even after they have finished their childbearing because it has got an immense therapeutic benefit, and this is something that we as gynecologists should be focusing on, monitoring and supervising these women so they do not land up with a metabolic X syndrome or with any cardiometabolic diseases. So the benefits of insulin sensitizers is it reduces insulin resistance, which is one of the pathophysiologies of PCOS. It can treat hyperglycemia in patients of PCOS, which is associated with established diabetes. Can cause weight reduction and improvement in their lipid profiles. Can be an option in patients who are at risk of the combined oral contraceptive pills, like patients of factor V laden mutations, or patients who cannot tolerate the contraceptive pills, or patients who want to keep their options of fertility open and do not want to take pills to regularize their periods. And in thin, lean PCOS, where lifestyle modifications are unlikely to be effective, the metformin will help us to reduce their hyperinsulinemia. There is an excellent safety profile for metformin and can be given in most high-risk patients. Now we have good Indian data which has compared use of metformin and myo-inositols versus metformin alone in patients of PCOS undergoing ovulation induction. It is a data of over 120 infertile patients who were divided into two groups. The treatment group of metformin 500 milligrams and myo-inositol 600 milligrams given 3 times a day, and the other group of metformin 500 milligrams given alone 3 times a day. And when you look at these graphs, you can easily see that the group of metformin and myo-inositol combination gave us better fertility rates, gave us better improvements in skin problems, and also their hormonal parameters were showing better results. So the combination of metformin and myo-inositol improves fertility, skin problems, and hormonal parameters, particularly in the obese women, in the severe insulin resistance, or even in women with perimenopausal age having symptoms of metabolic X syndrome. The synergistic action, because they act through different pathways, brings about a significant reduction in the dose and gives you better or added efficacy in these patients. So at this crossroad, as I said before, we have the procedure of ovarian drilling, particularly to be considered in women who have got failed medical treatment, previous history of hyperstimulation. It has to be used with caution. I think it's an excellent procedure in safe hands. Over-enthusiastic drilling can lead to a massive destruction of the ovary, leading to some women having poor ovarian or premature ovarian failures, and the surgical risk, the anesthesia risk, and risk of adhesions if the ovaries are not cooled off before finishing the procedure. So ovarian drilling should also be a part of the armamentarium for treatment of thin, lean PCOS. So when do we bring in the gonadotrophins? These are powerful ovarian stimulation agents to be used only in failure of the oral drugs, particularly now with letrose, or even if you have used clomiphene, at least 3 cycles of clomiphene or letrose and no ovulation. 6 cycles where ovulation is happening but no pregnancy, or women exhibiting side effects like early repeated miscarriages, persistent cyst formers, or luteinized unruptured follicles, you should quickly move on to gonadotrophin use. Recombinant gonadotrophins are better in PCOS patients which show persistently high LH levels. Although the levels are very high, you will not get a recruitment of follicles, and such patients could use 1 or 2 cycles of the birth control pill to get their LH levels down, and then start off with mild, low, chronic low dose stimulation with recombinant gonadotrophins. The added benefits of recombinant gonadotrophin is that there is no batch-to-batch variation since it is not a human product, potential unlimited supply, no risk of infection, no risk of any contamination, and no risk of antibodies forming, which can be seen with urinary gonadotrophins. Women with PCOS, as I said, can have premature LH surge or can have persistently high LH levels in their cycles. And now with the availability of antagonists can be used even in IUI cycles. It can be used flexibly. It suppresses the LH. It works instantaneously. In 20 minutes, the LH level will come down in patients who are given antagon. And antagon can be used as a trigger in those patients. You can use an agonist trigger in an antagon cycle, thereby reducing the risk of hyperstimulation in COH in ART. The antagon used in IUI is particularly in premature LH surge. So if your LH level starts rising when the dominant follicle is 14 or more, you could give the antagon to allow this follicle to grow to maturity and then trigger this follicle, ensuring that there is no premature LH surge, thereby ensuring no cyst formation and complete rupture of the follicles. But ladies and gentlemen, what is the eye opener in PCOS? Every time we come to the same thing, and it is an eye opener, it is something that we have to emphasize to our patients. We have to counsel young patients and their carers, their mothers, in fertile reproductive age, the couple, and it is the BMI. Weight loss is the first and the foremost thing that women should do in PCOS. Large number of studies in IVF has shown that the higher miscarriage rate in patients in PCOS as compared to non-PCOS patients is not because of the oocyte morphology or the ensuing embryo quality or any metabolic activity or dysfunction in the pre-implantation embryos or the endometrium. It is very linearly linked to the BMI. So IVF outcome in PCOS patients is related to BMI, and if we can get our patients to lose weight by diet, exercise, and medications, we would have a better oocyte quality and a better outcome, particularly a better live birth rates in our patients. So management of anovulatory PCOS is lifestyle modification, which has to be regularly emphasized to the couple, to the patient. Weight reduction by hypocaloric diet, exercise, and as I said, a 10 kg or a 10% weight loss will bring about significant metabolic changes. And that itself will give us a 30% increase in our pregnancy rates in the PCOS patients. But we know that there are certain patients who cannot lose weight, who are so grossly obese that for them getting up and doing the daily chores itself is very difficult. In these patients and in patients where you think that you may have to put them on medications, the anti-obesity drug works well. The only FDA-approved drug for treatment of obesity in infertility is orlistat. It inhibits the intestinal lipase activity, thereby inhibiting fat absorption. Obviously, it has some side effects, which include steatorias, flatulence, that can be reduced if the patient adheres to a low-fat diet. And in very rare cases, we have seen patients coming back with some hepatic abnormalities. Bariatric surgery is another option in women who are morbidly obese or in BMIs of more than 35, 38, 40. The bypass procedures, the malabsorptive procedures, and the restrictive procedures are the three main types of bariatric surgery. But what can be considered in women who are interested in childbearing is the use of the gastric loops or the gastric bands. These bands can be released in pregnancy, thereby allowing the pregnant woman to eat adequately, because we know that patients who have got bariatric surgery land up with malabsorption syndrome, typically malabsorption of essential proteins, essential fatty acids that can lead to IUGR in babies. And hence, you should wait for a minimum of 2 years if any bariatric surgery has been done, particularly the malabsorption or the bypass procedures have been done. But in young women, the gastric band works very well. There are newer pharmacological agents like the dipeptidyl peptidase or statins, which are now used in grossly obese women. But a very cheap supplementation is vitamin D supplementation in PCOS women, which will improve the oocyte qualities. I think it is very important in polycystic patients not to overstimulate them and cause the OHSS, because this is an iatrogenic problem, can lead to severe morbidity and in some cases even mortality. So there are various different things that we can do to reduce the chance of OHSS. A very good option is use of cabergoline, which will not decrease your pregnancy rates, but will dramatically reduce the chance of OHSS, use of colloids, particularly albumin, and now cryopreservation of embryos by vitrification, which gives you excellent thaw rates, which gives you excellent frozen embryo cycles and pregnancies in FET cycles. AMH can be used in PCOS patients, not to be used routinely, but can be used in patients, particularly those who are going for ART treatments, because you can plan your protocols according to the AMH. If the AMH is very high, I think the antagon strategy by using agonist as trigger, cryopreserving, and then transferring the embryos in a natural or a modified natural cycle gives you excellent results. In patients with normal AMH, you could either go for the long down regulation or even the antagon cycles. And again, in patients with low AMH, you could go for the short antagon cycles. So to summarize, lifestyle modifications, pharmacological therapies, surgical interventions, be it the ovarian drilling or the bariatric surgeries, and please, monitoring and supervising these women even after their childbearing age to prevent the metabolic X syndrome will go a long way in looking after our women with PCOS. Just to recap the guidelines of the international evidence which was released in 2018, which endorses Rotterdam criteria, highlights that particularly in the adolescent or the young women, USG is not necessary for diagnosis. They do not advocate AMH for diagnosis. Management is multi-pronged, reproductive, metabolic, and psychological. Important to counsel patients, to counsel their relatives, counsel their caregivers, educating the patient, empowering the patient with the knowledge to look after ourselves, multidisciplinary care, lifestyle interventions, all goes to help this patient to lead a healthy life. The birth control pill is the first line of pharmacological management for menstrual irregularities and hyperandrogenemia. The low dose pills are to be preferred. Metformin alone or in addition, particularly in cases of hyperinsulinemia. Letrozole as a first line of pharmacological intervention in the infertile group. Clomiphene and metformin both have a role alone and in combination. Gonadotropin should be the second line of treatment for ovulation induction in IUI. And IVF is the third line where all other ovulation inductions treatments have failed. Thank you very much for a patient hearing. Thank you for spending time with me. I'm happy to take any questions. Before I end, I would like to thank ISAR. I would like to thank Dr. Jaideep Malhotra, past president of ISAR, who initiated these webinars. Dr. Prakash Trivedi, the present ISAR secretary. Dr. Kedar Ganla, the Secretary General of ISAR, and Zydus for all their logistic supports, and Doc Mode for being so cooperative even in these stressful times to conduct this webinar and bring it to your doorstep. I hope you have a lovely, safe, and a secure till we all come out of this crisis and we all are back to our routine mad world. Thank you once again. I'm happy to take up any questions. Go on the question.
So it is in the sheet that we sent.
Yeah, I'm just opening the sheet 2 minutes.
Yeah.
Okay, so I'm taking up a question from Dr. Jayashri from Pune. How can therapeutic interventions help in tackling PCOS? I think I've spoken quite a lot on that. Before therapeutic interventions, I think it is very important to talk about lifestyle interventions. Then put your patient on some treatment. If your patient is not looking at fertility, just looking at regular menses, the birth control pill works effective. If they're looking at fertility, obviously starting off with letrozole, then moving on to a combination of metformin, letrozole, and then moving on to gonadotropins will help you to tackle PCOS. Looking at the question from Mangalore, from Akshata, what success percentage is expected in an ovarian drilling, and what medications are generally effective? Akshata, when you do ovarian drilling in the right patient, in the right amount, I think almost 20 to 25% of them will get back to having regular menses. And if there is no male factor, I think a large percentage of them would conceive once they start getting regular periods. This is a question. The next question is from Prajakta from Mumbai. Some other risk factors of PCOS. Yes, I have seen that patients of PCOS, particularly those who have got allergies, those who have got asthma, those who have got beta thalassemia have a higher risk of hyperstimulation. So if you have any of your beta thalassemia patients, patients who have got already asthma or any other allergies, these are the patients who have a high risk of hyperstimulation. From Dr. Deepa from Delhi, how effective is a surgery in comparison to medications? At what level the surgery should be considered? Now, you must understand that if your patient is an obese patient, obviously lifestyle, weight loss is going to be your main aim. And in such patients, doing laparoscopic ovarian drilling is not an effective treatment option. I think laparoscopic ovarian drilling works in thin lean PCOS or in patients in whom you have tried medical management of ovulation induction and it is not working. Rakhi from Nagpur, what other health conditions can occur with PCOS? Diabetes or highly susceptible to diabetes, cardiac problems, as we call them as a metabolic X syndrome, can happen in these women. Particularly, you have to be very careful, and women after their childbearing generally do not care much for their health as far as PCOS is concerned. And this is a major problem for those women landing up with impaired glucose tolerance or getting into frank diabetes. These are the very women who are at risk of gestational diabetes and need to be monitored. Quite often, we advise these women to continue the metformin throughout their pregnancy to reduce their chance of gestational diabetes. There's a question from my friend Parag from Pune. Is there any role to do AMH in adolescents with PCOS? Absolutely no role in doing AMH in adolescents with PCOS because it is going to be very good and very high, particularly in PCOS. If you're suspecting some granulocyte tumors in these women, then you know that if you get abnormally high AMHs, they could be a signal for other ovarian tumors, particularly granulocyte tumors. Parag is also complimented on saying a very good presentation. Thank you, Parag. Coming from a friend like you, I know it means a lot to me. Dr. Harish from Cochin, what other health conditions can occur with PCOS? Cardiac problems, lipid irregularities, diabetes, obesity, and all the problems of obesity can occur with PCOS problems. Dr. Pandit Palaskar has said, do you recommend freeze-all protocols for PCOS? Now, frankly, in our unit, the protocol is that if any patient gets more than 15 oocytes, we would like to freeze all and then transfer them in a natural, or more better is a modified natural because you have some control on that cycle. So any patient who gives more than 15 oocytes, I would like to recommend freeze-all rather than transferring in these patients because they would be at a very high risk of getting hyperstimulation if they conceive. Dr. Ketan Parekh, kindly mention antagonist and agonist dose and at which day of cycle. Now, in an IUI cycle, if you persistently find that your follicles grow well, but once you give the trigger of HCG, they do not rupture, you could be dealing with a patient of premature LH surge. So your LH has already surged maybe 2 or 3 days prior to you giving the HCG injection, and that's why these follicles do not rupture. In such cases, it is always a retrospective diagnosis, and you could actually, in the next cycle, monitor their ALH when the leading follicle is 14. And if you find that the ALH levels are rising or have already risen, you could give the antagonist to such a patient, bring the ALH level down, allow this follicle to grow, and then give the HCG trigger so that your follicle will surely rupture. As far as the agonist dose, which is given in an antagon cycle. It is 0.1 leupride, or it is 0.2 decapeptyl, which is given as a trigger in ART cycles. Dr. Joshi from Surat has said, can you explain a procedure of treating infertility in PCOS? Yes, 3 arms to it. One is lifestyle, second is psychological management and counseling of the patient, and third is putting them on treatment, ovulogens, that is letrozole, then gonadotrophins, and then perhaps IVF. Dr. Fatima from Mumbai, how does surgery affect other symptoms of PCOS? It will also get hyperandrogenemia down. It will get your LH levels down. And that's why these patients start getting regular periods, because of the decrease in the hyperandrogenemia and LH. Pandit Palaskar has also asked a question, is in the antagon agonist trigger cycle, do you recommend double trigger? Frankly, no, I do not do routine double trigger. In an antagon cycle, you can give only agonist. However, if you have had patients who are on the birth control pill in the previous cycle, I have seen sometimes they can give you an empty follicle or reduced number of mature oocytes. In those patients in whom you have put them on the birth control pill in the previous cycle, you may consider giving them dual stimulation or double trigger, as we say. But I do not routinely recommend in all patients of antagon. I think it was wonderful interacting with you all, and thank you very much. Are there any more questions? I can't see on my screen.
No, sir, I think that's it.
Okay, so thank you to Doc Moore for bringing me so close to all my colleagues in this day and age of safe distancing. And thank you to Isa once again for having these wonderful webinars where we presently get a little breather to update ourselves. And thank you very much to my listeners and all those who asked questions. Thank you once again. I'm signing off. This is Ameet Patki.